Hi, everyone. Thank you so much for coming. My name is Jennifer Cummings, and I'll be moderating our panel. Our first panel of the day, we're calling A Country in Crisis, Technology's Role in Overdose Prevention. We have three awesome speakers with us here today. The first is Laura Thomas, who is the Director of HIV and Harm Reduction Policy for the San Francisco AIDS Foundation. She is also a longtime member of the San Francisco HIV Community Planning Council and serves in the public health seat of the San Francisco Entertainment Commission. Laura has a long history of advocating on public health issues and has previously served on the San Francisco Methamphetamine Task Force, the Supervised Injection Services Task Force, the Cannabis State Legalization Task Force, and the Mayor's Hepatitis C Task Force. Next we have Maurice Bird, who is the Director of Training and Business Operations at the Harm Reduction Therapy Center. He has worked as a harm reductionist since 2004 and has provided mental health services in schools, private practices, jails and prisons, at needle exchanges, and on the sidewalk with people experiencing homelessness. Maurice has facilitated a unique harm reduction marijuana group for young adults and is trained in MDMA and ketamine-assisted therapy. He is also a published author, co-writing the chapter Dealing with Drug Use After Prison, Harm Reduction Therapy in the book Decarcerating America. And last we have Ale Del Pinal, who founded the grassroots harm reduction organization Punks with Lunch in 2015. Since then, LA has worked at the Homeless Youth Alliance as a frontline worker while continuing to help grow Punks with Lunch into an organization that aims to be a participant-centered organization and uplift people who use drugs, do sex work, and experience or have experienced homelessness. She currently holds a paid position at Punks with Lunch, serves as a board member for the Harm Reduction Therapy Center, and is a culture of health leader at the Robert Wood Johnson Foundation. Please join me in welcoming them. So just to ground us in the topic, drug overdose is the leading cause of accidental death in the US, with over 100,000 people dying from drug overdoses last year. Growing evidence supports the positive impacts of harm reduction programs such as syringe services and supervised consumption centers, but the US has been slow to adopt them. Our three speakers today take a harm reduction approach to providing health-based care for people who use drugs here in California. And we've asked them to join us to discuss some of the challenges facing harm reduction efforts and potential routes forward in addressing the overdose crisis. So I want to start by asking you all, what are some of the barriers to compassionate overdose prevention?
I mean, the number one, well, there are two interrelated ones, and that's criminalization and stigma. And the fact that substance use and possession is criminalized makes it complicated and difficult to provide services, and it's inextricably intertwined with the stigma against people who use drugs, and makes policymakers and our culture at large, despite the fact that the vast majority of us consume substances of one sort or another, we create an enormous amount of stigma around the types of people that we perceive to be consuming some of those types of substances, which is a set of very racialized stereotypes and stigma that makes us feel like people who use drugs are less worthy of care and compassion, even though most of us are in fact people who use drugs. So it's in some ways an internalized stigma and sort of respectability barriers and so on. But ultimately, it has meant that people who use drugs are seen as disposable, as not worth caring about, and not worth creating policies to lift them up or give give people the tools that they need to take care of themselves.
Yeah, can I add to that? I think there's the good old classic things like racism and classism and sexism and homophobia and transphobia, like all those good old classic things. It's indicative in San Francisco in particular that there's more black folks that are overdosing than anybody else right now, dying from overdoses. I'd like to start by asking this question, if y'all don't mind. How many people in here use drugs? Oh, we got a lot of hands. Good. Let me re-ask the question. How many people here drink coffee or caffeine of some sort? So that's about all of us. That means, like Laura said, like everybody here is a drug user. The problem is that we often think about drugs as good drugs or bad drugs, and then who's using those drugs as well too, right? But if we kind of normalize it a little bit, it kind of reduces the stigma a little bit, and it helps us be a little bit more compassionate whenever we understand that we're all in the same community on some level. Throughout human history, there has been just about 0 cultures that didn't have some sort of drug use inside of their culture.
I think speaking like from the perspective of somebody who works with unhoused people, it's literally being unhoused itself is like a barrier to getting compassionate overdose prevention care. Yeah. We see a lot of sweeps. We see a lot of people who are unable to get any kind of medication and therefore aren't able to keep their Narcan. And it's as simple as having a safe place to put life-saving medications, including naloxone. Mm-hmm. And it's also, as a grassroots all-volunteer organization that networks a lot with other grassroots organizations around the country, it's also like it's really hard to get access to naloxone. Mm-hmm. And we work primarily with people who use drugs. I believe that harm reduction programs are the programs that distribute the most amount of naloxone in this country. Yeah. And primarily to people who use drugs, and those are the people who are saving the most lives. And I think that just accessibility in general, just like speaking from like logistical things, mm-hmm. accessibility for harm reduction programs is very low because a lot of the funding for some other states and sometimes even here in California will go to EMTs, or naloxone will go to EMTs or police officers as like a prioritization versus the people who are saving the most lives. Mm-hmm. Mm-hmm.
Yeah, I think we all know that police are not well trained to handle mental health crises. As you mentioned, they are the first responders right now. So I'm wondering who should be the first responders, or can you envision a different system as to how we deal with drug policy?
Mm-hmm. I mean, to reframe that a little bit and echo Ali, people who use drugs are the first responders. Mm-hmm. It's people who use drugs, people who have family members who use drugs, people who used to use drugs, mm-hmm. Who are reversing the vast, vast majority of overdoses in this country. And they're the ones that we should be lifting up as the heroes mm-hmm. Of this overdose crisis. And, police are not well trained in a large number of different things. It is, one of the sort of historical shames of this country that we've been using the police to solve any number of different problems that they are profoundly unsuited for, and in fact often make worse. Yeah. Aggressive policing is, research has shown, I mean, we don't even have to go with common sense, we can go with research. Research has shown that aggressive policing increases overdose rates. Aggressive policing, as Ali mentioned, people lose access to their Narcan, naloxone, which reverses opioid overdoses. Aggressive policing will make people rush shots, hide, in places where they won't be found if they overdose. There are a bunch of different ways that policing increases overdose risk.
Yeah.
Criminalization generally also increases overdose risk. Being incarcerated is one of the most substantial increases in overdose risk the first 72 hours after somebody is released from incarceration or from an abstinence-only residential treatment facility. Their overdose risk skyrockets. So these are all things that increase overdose risk. Policing that disrupts drug markets also. In San Francisco right now, there's this whole sort of conversation about fentanyl and, the evil drug sellers who are, you just have to pick up any paper and you'll see this whole conversation. But the reality is that policing that disrupts markets leaves people more vulnerable to overdose because it makes the drug supply less stable, less secure. People are purchasing from people that they don't know, and that also increases overdose risk. So that's a whole bunch of ways that policing and police increase overdose risk and increase overdose fatalities. So it's, not even getting into the fact that far too many law enforcement officers and EMTs buy into this utterly absurd myth that touching fentanyl can be dangerous to you, which leads them to wear hazmat suits and things like that. It's utterly, utterly ridiculous. And we can talk about why, but I'll just say, leave it at that. It's utterly ridiculous. So, if nothing else, I want people to, if you see police being cited as a source in a newspaper article or anywhere else as an expert on substances or people who use drugs, please discount that entire article, and certainly discount anything that they say. Police are not experts on these topics and in fact are creators of harm and purveyors of misinformation. That was a long rant in response to your question, but just to reframe things a little bit.
Yeah.
First I want to give a shout out to drug dealers, by the way, because the FDA is not regulating drugs, so drug dealers are, by the way, so they take care of a lot of people. Don't get me wrong, we get the dose wrong often, right? But it's a shout out to drug dealers. Who should be first responders? I just want to say something pretty simple. Is one, like we said, people who use drugs, family members, all the rest of those things, and all of us should be first responders. You should be first responders. How many people in here have Narcan or naloxone on them right now? Thank you, see? So we all need to be first responders. Go to your local needle exchange, Google it, go to your local needle exchange and get taught how to administer Narcan. It takes 5-10 minutes. And then you can be somebody who saves somebody's life.
You said exactly what I was going to say.
Because we have the same.
Yeah. I can't tell you. It's really interesting when I do Narcan trainings. Specifically, I've done Narcan trainings for nurses in medical school or who had no idea how to administer Narcan. And one of the questions that I had asked was why don't you teach this? Oh, because it's not necessary, because we're not on the front lines. And one of the, they're not the EMTs, they're not the first responders. What I ended up replying was, well, you walk down the street, checking up on somebody, showing human compassion and care can go a really, really long way to humanize the person that you see laying down on the ground and unsure if they're conscious or not. To just check in it means everything. And it could be the difference between life and death.
Yeah. Just to see if someone's breathing.
Yeah.
It takes us 2 seconds to see if someone's breathing.
Yeah, thank you so much for that. I'm wondering if there are any positive examples of drug overdose prevention programs or drug policy, either here in the U.S. or internationally, that are really doing it right.
Yeah, Laura, I know this is your thing.
Go for it.
But there are safe consumption sites all over the world and not in the U.S., not legal ones. I want to also give a shout out to crack houses and dope houses and trap houses, because those are the safe consumption sites that we've had to create as communities. But in around the world, there's been 0 overdose deaths at all of these safe consumption sites, and we're up to 130 or 40 now. Is that right? Is that the number? So there's a great example of this. And there's other things like in San Francisco, in Punks with Lunch, right? These are folks that are actually talking to people on the front line. You're actually touching and working with people who are using drugs. They're becoming educators, and they're educating other people.
Yeah, and just to update that, what Maurice said a little bit, New York City last fall opened 2 overdose prevention centers, and so far they've had thousands of people go through their sites, and they've reversed dozens of overdoses that might well have been fatal otherwise. So, they get called by a bunch of different names, but overdose prevention centers, supervised consumption services, give people a protected, legal, safe place to use their substances with trained staff on hand to recognize the signs of an overdose or potential overdose, intervene if needed, and they also turn into places where people often feel welcome and respected for the first time, or are able to bring their full selves to that place, and become opportunities and possibilities for connecting people to other services, for building trust, for building relationships, for just giving people some respite. And they've been extremely successful around the world in certainly in preventing overdose fatalities, as Maurice said, of the, literally millions of substance use incidents, there have been plenty of overdoses, but there's never been an overdose fatality because people have been able to intervene. And so they've also been very effective at linking people to treatment. People who use overdose prevention centers are more likely to go into treatment and more likely to stop using substances altogether than people who don't. So they've also had a big impact on, syringe litter in the neighborhood, public drug use, some of the things that often neighborhoods care about. So they reduce, the extent to which people go to the hospital or to emergency departments. So they reduce, taxpayer funding that's needed to go to those things. So they've been very effective in a whole bunch of different domains for a whole bunch of different sort of stakeholders. But it's absolutely something that is long overdue in San Francisco, in the Bay Area, in California. Having 2 sites in New York is great, but it's nowhere near what we actually need.
I think on a little bit more of a smaller scale, what I've seen has been super beneficial is accessible education and information about overdose prevention. TikToks, Instagram posts, I have seen so many more people know how to respond to an overdose, or even how to use drugs a little bit safer. I know from personal experience, before when I was using, I had no idea how to respond to overdose. I had no idea that mixing any opiate with alcohol would increase my risk, and had I known, I probably wouldn't have been using so dangerously. And it's pretty amazing to see that this information that was almost like hidden as I was growing up, like all you had was DARE, or like educate, like don't use drugs in school education, now is accessible to like teenagers. It's accessible to people who who are using drugs, it's accessible to everybody. And I think that is huge. It's absolutely, it is, to have that in schools. I think that there's even a program, the Sacramento Harm Reduction, I don't remember their name, but there's a needle exchange in Sacramento that goes into high schools and gives out safer sex supplies, and I believe naloxone as well, which I think is incredible, because I know from personal experience that there are people who are, using opiates and other drugs in high school.
And I think we have a moment here in this country to take advantage of it, right? The president said harm reduction, and our phone line blew up, by the way. We do lots of training, so people call us and say, hey, can you talk to us about harm reduction? Along this line is, we've also been getting a lot of requests for us to help people edit their material just to have more of a harm reduction feel to it. So we have a moment in this country that I think we need to take advantage of. Don't get me wrong, it will be watered down in some ways that I'm worried about, but we have a moment for some energy right now.
Yeah, I'm really excited to hear that, and this was something I really wanted to ask you all about. We know that abstinence-only education doesn't work, and as LA already mentioned, with technology, there are new ways to reach people with information about how to use drugs safely, and I'm just wondering if you all can talk a little more about effective ways of communicating this information, or if there are any technologies that you all have seen that are really helpful in supporting drug users.
I really sort of pondered this question last night, and I don't know. One thing, I think that increased education. Harm reduction isn't something, I was trained as an MFT, right? Harm reduction is not taught in schools. It's not taught in colleges. Abstinence-only models are taught in colleges. So we need more of that. There's a couple of professors out there that are working in some of the colleges that are teaching people about harm reduction, but we need therapists, nurses, doctors. We need everybody trained also with the option of harm reduction. Because harm reduction includes everything from abstinence to safer use and controlled use and moderation, and that's often something not said. So we need that inside of the school. There's also, just to get more specifically to the question, there's also this app that's called the Canary app, that actually helps people, alerts people if you're using, and if you don't respond in a certain amount of time, people call you and then maybe they can get you some help. And I was wondering about, if we're thinking about technology, I'm not a scientist, I'm not an engineer, I don't know how to do these things. But I'm wondering if there's ways that people can self-administer Narcan. And if there's technology that can measure people's heart rate getting too low or their breathing getting too low, and then there's Narcan is administered once this happens. If you can put on a bracelet or something, I don't know. But I think we have to really get into our imagination, and really try to figure this out. But that means that we also have to accept that people are going to use drugs, regardless if they're legal or not. People are going to overdose on drugs, regardless if they're legal or not. So it's a moral decision for me in some ways that if we just ignore people and we don't invest into this, 100,000 people are going to continue to die every single year. So maybe just putting some investment in that and using our imagination together.
Yeah, there's one, sort of to take it in a different direction, the other technology that is also underused in the U.S. for political reasons, legal reasons, is drug checking. So and this comes in a bunch of different forms, fentanyl test strips. How many people have heard about fentanyl test strips? Mm-hmm. So these are, they have limited utility in a lot of different contexts. Like if you're already purchasing fentanyl, you don't need to know that there's fentanyl in your fentanyl, right? But if you're already purchasing opioids in this country, the odds are very good that it's got fentanyl in it. But if you're purchasing something that you believe to be cocaine or methamphetamine, for example, testing it for fentanyl may be a very smart idea. The next step above that is being able to do drug checking with fancier technology that can give you more information about not just fentanyl, yes or no, but how much fentanyl, or are there other things, are there benzos in it, is there xylazine in your drugs? And so this is, FTIRs are a sort of small infrared technology that can give you more information about what is in a particular substance. It's used in like industrial contexts and so on, but is increasingly being used to do drug checking, either like at festival settings or in syringe access programs, for example. And then the next step beyond that is sort of like a mass spectrometer. And these can be, they each have different levels of sort of accessibility and technology, and it's, it's a trade-off of like just the test strip is easy to use, but it only gives you limited information to a mass spec, which is, very expensive and lives in university labs, but gives you a lot of information on it. And then there's a question of how do you get that information back to the people who are using drugs in a way that is useful for them. Like, it doesn't necessarily do any good to say, like, yes, there's xylazine around in the drug supply without saying more about what that is, what it does, what that means, ways for people to develop a safety plan around it. But I think drug checking, especially the sort of FTIR type drug checking, is really an underused technology in the US and has the ability to really give people who use drugs much more information about what they may be using, so that they may choose not to use that particular batch, or they may choose to use it differently. It also gives, those of us who work in harm reduction programs the ability to educate people, hey, be on the lookout for this, or, people have had bad experiences with this, or people have had good experiences with this, right? Like, it doesn't all have to be about reducing harm. Some of it can be about, like, this is a really good batch. Some of it can be about enhancing people's pleasure and enhancing people's experience. But it can also, be information for clinicians. If you're seeing this particular kind of, we've got more xylazine out there, so be on the lookout for these skin infections, things like that. So that's one technology that I want to see us really dramatically expand accessibility, and I think that will have has the potential to really have a dramatic impact on how people use substances and what kind of information they have about it.
Yeah, it's interesting because it reminds me of when I was working at the Homeless Youth Alliance. We were collecting samples to get tested at the lab, and one thing that kind of came to my mind is that you need the buy-in of people who use drugs, and you need their participation in it. So none of these technologies are going to work without the input of the people who are going to be utilizing it, which requires, to not be stigmatizing and to be compassionate and to build rapport with people. Like, technology is great, and it was pretty incredible to see, what is in the drug supply in San Francisco at that time. Yeah. But it wouldn't have worked without the trust that was built in that setting. So I don't know where the technology is going to go, because that's not really where my mind goes necessarily, but more of in order to make this technology work, and in order for it to be beneficial for people who use drugs, to have participants, to have the people who use drugs involved in the creation of that technology, and have it be paid, have them be paid for their expertise and knowledge, is the only way that any technology will be useful going down the line.
And Ale and I worked at the Needle Exchange together at Homeless Youth Alliance during this time when we were collecting things. And there's a term that we use in this field, and in lots of fields, it's called evidence-based practice, which is great, right? That means that you've done lots of research. And what Ale is talking about is actually practice-based evidence, meaning that you go to the people who you want to help, and you ask them for the information, and that becomes the evidence. Not the research that you've read, not the research that we did 10 years ago with who knows. You actually go to the people and make it very, very tailor specific to that population.
Yeah, yeah. And so I'm wondering how scientists and community members can get more involved in supporting compassionate overdose prevention. And yeah, I know, Maurice, you were saying you're not a scientist or engineer exactly, but feel free to throw out all ideas. You know, I think we're really open.
Well, I mean, you know, one, just support harm reduction. We use a lot of science for lots of stuff, but then when it comes to drugs, we throw that all out the window, and we get a little hysterical about it. And we think of things like when people are using drugs, that the only option that people should have is to stop using them. And I'll tell you, I know personally, I've been a therapist and worked with people for the last almost 20 years, and I can tell you, I know people that drugs have saved their lives, like literally saved their lives. So we need to get the science actually in line. We need to stop using words like addict and addiction. That's pseudoscience. You're scientists. These are not actual. These are terms that we've decided as a culture that we're gonna accept. So let's get a little bit more specific. You know, when somebody says someone's an alcoholic, I'm like, well, what does that mean? Tell me how much they're actually drinking. What does that mean? You know, because we have this setup in this country, by the way. Somebody says, you drink too much, and I say, no, I don't. That person says, you're in denial. That is the setup that we have in this country. So buy into harm reduction, right? Actually look at the science. Read Carl Hart's science, who's a neuroscientist, who's like the smartest person in the world I know around drugs, and he's often pushed to the side because one, he's a black man, and two, he's a black man that acknowledges that he uses drugs. So they're like, let's not listen to him, and his research is the dopest research out there. So actually read the research, and don't buy in as much into these ideas around being hysterical and people's opinion becoming fact. It is not a fact that drug use is a disease. Period. Stop. Drug use is not a disease. If you look at it through the lens of a disease, then you're not including the psychology and the sociology of something. I cannot stop having diabetes all of a sudden. I can stop using drugs all of a sudden. It's a little more complicated than that, don't get me wrong, but we cannot. That's hysterical to me. And I'll share how it's based in racism, by the way. During the 80s, when there was a crack epidemic, we didn't call it a disease, by the way. We called it a moral failing. And you know what we did? We locked up everybody who used drugs. Guess what? We have an opiate epidemic going on right now. And guess who started dying? Middle America, middle class white kids. Guess what? All of a sudden it's a disease. Because if you have a disease, then you can get treatment for it, and we don't need to lock you up for it. So we need to stop this noise, which is, again, someone's opinion that has become fact. Drug use is not a disease, period, stop. It's a biopsychosocial phenomenon. That's what it is.
And I mean, just to sort of amplify that, learn the science and stand up for it. You know, I think there are fewer areas or domains where there's such a huge disconnect between what the evidence shows works and what our actual policies are. than harm reduction and substance use. I mean, maybe criminal justice is probably the other area where there's such a huge disconnect between the evidence and what the policies are. But, you know, learn the science. Harm reduction works. Housing first works. Many of the things that we've been doing just do not work and, in fact, increase harm, like criminalization, like stigma, like, you know, forced or coerced treatment, are things that don't work and actually increase harm often. So, yeah, learn the science and stand up for it. There needs to be more sort of light shown on these conversations. And you know, stand up for your local harm reduction program if they're being attacked by NIMBYs who are saying, you know, they're the cause of, you know, syringe litter or things like that. Get to know them and stand up for them. And then the other one is, you know, if you are someone who uses substance, you know, and you're in a situation where you can be more open about that, speak up and disclose your use. It's one of the most powerful anti-stigma, you know, messages that we have, is being able to say, I'm someone who, you know, is this stigmatized, like I am a queer person, you know, I'm a person who formerly experienced homelessness, like whatever the stigmatized status is. Not everyone can do that, can disclose their use, for sure, because of the criminalization and the stigma, right? But if it's something that you can do, disclose your use and help to normalize it. And the fact that, you know, people who are, you know, successful by whatever definition you want to use for that are also using substances on a regular or irregular basis, just to help kind of complicate those narratives about who uses drugs and what the impact is. So those are the things I would say that everyone can do. And yeah, get naloxone if you don't have it and learn how to use it.
I love what both of you said. I also think like it's really important to, and I will say this forever and ever, is to talk to the people that you're looking to help. The people, you know, every single, well, not every day anymore, but usually when I'm going out on outreach, I'm talking with people that use drugs. I talk with my friends, talk with people every day, talk with people who use drugs, I guess. I use drugs. And people are ingenious. Like we seem, you know, I don't have a degree. A lot of the people that live on the streets where I work do have degrees and are just unhoused. They're ingenious. They have ideas. They are smart. They have survived in horrendously, like just horrendous circumstances due to policy failure. And the reason is because they're not seen as people. They're not seen as part of the community. They're ostracized. And, you know, it's really important that I believe that building community with the people that you aim to help, building trust, building compassion is so important. Look at the person, not the problem, right? And everything that these two said as well.
Thank you so much. We have time for maybe one more question, so I guess I want to ask about moving forward and trying to change science and public health policy. Maybe are there lessons that could be learned from the efforts to legalize marijuana, or just anything else? Any other lessons moving forward?
There's so many lessons to be learned from legalizing marijuana, for sure. And my previous job before this one, I was working for an organization called the Drug Policy Alliance that has done a huge amount of work to legalize cannabis across the country, including here. And there are so many lessons to be learned, and I feel like we've gotten better and better at it, but one of the most, I think, sort of core things about legalizing marijuana is ensuring, and it gets to capitalism and racism and the ways that capitalism will just fuck up everything it touches, is that we need to be very intentional about the ways that we are legalizing substances to ensure that the benefits accrue to those who have been harmed the most by the war on drugs, and that just legalizing a substance in our, in the context of American capitalism will just sort of shove profits higher up the food chain unless we're very intentional about how we do it. And I feel like, California took some steps in that direction. New York State's cannabis legalization has gone even farther, their efforts at the federal level, but ensuring that we are looking at these things through a racial justice and a racial equity lens as we do it. And so that, I think, is one of the most sort of core lessons we need to learn. I do think that, decriminalization is kind of the next thing that's on the table. For, Oregon passed a ballot initiative several years ago around decriminalizing personal use and possession. That's a good interim step. Ultimately, we need to get to safe supply where people who use substances are able to access, the same way that I can walk into a liquor store and I can purchase liquor of, exactly the kind I want. It's carefully labeled. It's, production is regulated. I am sure that I'm purchasing a safe product of the strength that I want. I can do the same thing in a cannabis dispensary now. That needs to be available for all substances, where we've created this, very artificial distinction between some substances are legal and some aren't. And many people may believe that that is in some way based on some scientific process or, assessment of the relative harm of these substances, and nothing could be further from the truth. It's entirely based in racist stereotypes, to be honest. Like, that's why that's why heroin is not legal, but Dilaudid is, right? Yes, there are lots of lessons to be learned and lots of ways we can do things better, and that needs to be the direction in which we're going thoughtfully.
Yeah, I think what also the legalization process of marijuana has done is, like Laura was saying, like sort of expose like capitalism in the ways that it hurts a lot of people, and the absolute hypocrisy now that people. They've erased the black market, which is great, right? Because black markets sometimes create violence. But the people that were selling the marijuana can't sell marijuana anymore because they've been convicted of marijuana charges. This is sort of hypocrisy and ridiculous to me. And to go further, I think too that we need to, end the war on drugs, period. Decriminalize all drugs. Period. There's models this like in Portugal, right? To get to the science again, like what we know is during Prohibition, alcohol use went up, skyrocketed. People overdosed at a rate never seen in this country because it was unregulated again, and we had one of the biggest crime rate waves that we've ever had in this country. We also have to remember that we're still underneath the Prohibition right now. And every single death, every single overdose death that we have in this country, you can directly link it to the government because they've decided to have prohibition. And we tried this from 1920 to 33, and it didn't work. And we're still doing it right now.
Yeah. I think it's also important to recognize that the people who are benefiting the most from marijuana legalization are the people who have the most money. And, people who sell drugs on a street level are people who, for whatever reason, are in need of that money and are usually low income or people who use drugs themselves. And I think it's really important to just keep in mind as decriminalization and legalization is talked about, that when that happens, some people are going to go out of business and experience a lot of hardship and poverty and loss of income because of it. And that is a capitalism failure. But it's something that's not thought about very often, I don't think, because everybody, the narrative is to not like your drug dealer, to not like the local drug dealer, because they are the reason for all of this. So that's kind of what I think of when presented with this question.
Awesome. Thank you so much. This has been an amazing discussion. We're now going to open it up to questions from the audience. So if anybody in the room has questions, if you could please go up there to the mic. And then also we'll have questions from the virtual audience.
Hello. Thank you all. I have a question about those first sites that you talked about starting in New York that have opened up. And I'm thinking, so it's great that we have these things now, but they're still existing within a bad environment, bad policy environment, and a bad environment of practice, even in New York, right? So what I'm wondering is that true in the other countries that are doing this better too? Do they also have like some decent stuff going on within a bad environment? And are there ones that have a broadly good environment?
Yeah, thank you. That's a complicated question. You know, when we think about good and bad drug policy, like some countries like Portugal are sort of notorious for having, you know, decriminalized personal possession some time ago. So there are overdose prevention sites in Portugal that are operating then in the context of decriminalized personal use. You know, Canada is the country that I know the best and went from having first one, then two, and now literally dozens of sites all over. And Canada is also, you know, like the US, like there's some provinces that are much more conservative and they're trying to shut down sites. They are some areas that are experiencing the same sort of sweeps of homeless encampments, like the downtown east side in Vancouver that's very similar to the Tenderloin neighborhood in San Francisco for a bunch of very similar historical reasons around housing supply. It's an area of concentrated poverty and a substantial number of overdoses. They also have a lot of overdose prevention services there. So it's, you know, I think overdose prevention sites have been broadly accepted across Europe, which often has a very different policing culture and criminal legal system culture. And so they're operating in a different sort of social context, and I think that's been very helpful for the adoption of services there. But I'm mindful, one of my former colleagues at DPA, you know, sort of who is a Black woman, pointed out, like, it doesn't do me any good to be able to go into an overdose prevention site to use drugs and be saved from an overdose just to be able to leave and be killed by police, right? Like, it's unless we need to be able to situate these things in the, you know, in the need to change the broader culture and to change the broader criminal legal system, that being able to hold one location safe for people is not the same as being able to make the world safe for them when they leave and walk out the door.
Yeah, I mean, just to kind of say, like, harm reduction is one piece of a larger issue, like a larger puzzle, right? One of my favorite things to say is harm reduction is just a step for human liberation. But we still need to look at like how capitalism, how it affects, low income, Black, Indigenous, people of color. You have to look at housing, the fact that there's 4 empty houses for every unhoused person in Oakland. Safe consumption site isn't necessarily going to fix them, not going to go, like, they're going to go back on the street. They're still going to use on the street. They're still going to use in unsafe environments and unhygienic environments, which leads to infection. You have to look, if you're looking at policy to get people housed, policy to get people health care, policy to get to reform or abolish the police, is instrumental to creating a safer environment and a safer place for people who use drugs. And all people.
Well, yeah, well, and I won't say much because I think y'all covered this lovely, but the only thing I will say about safe consumption sites in general is that we need to make sure that they're not set up as containment areas. Because that out of sight, out of mind thing, San Francisco, I think, is interested in this now because politicians are like, oh, there's a way of, moving people off of the street inside of an area so the tourists don't see them, right? Or we don't see them, right? I just want to sort of keep that that in our mind too. Like Laura was talking about, we have to think about it more than just the safe consumption side, all the whole parts of it, that, as Ale said as well.
Thank you so much for all of your really thoughtful answers to the questions so far. I'm Zoe. I'm the president of Aggies for Recovery at UC Davis. We work with students who are struggling with substance abuse, and we try to encourage either abstinence or harm reduction. Personally, I am 2 years clean of my drug of choice and actively practice harm reduction in my use of other drugs. And our goal right now is to try and get Narcan into the dorms so that RAs have better access to if a situation were to arise. And we are facing a lot of pushback from the university because of liability issues and not the lack of demonstrated problem. Like, people aren't dying right now, so why should we do anything about it? And I'm wondering if you have any insight onto how to maybe work around the liability issues or how to kind of spur up a bigger movement to make this happen.
Do you have a Students for Sensible Drug Policy chapter on your campus?
No, we don't.
Okay. So the college student organization that I know has worked on this a lot is Students for Sensible Drug Policy, and contacting them at the national level, they've done a lot of work around how to get naloxone and other harm reduction services on college campuses. And so I think they may have advice or, sample policies, things like that, stories from places where other college students have organized around this. So thank you for organizing around this. That's, fantastic and so needed. I don't know if they would be responsive. I mean, college administrators are a whole thing, but I don't know if they would be responsive to stories about college students from other places who've overdosed and saying we want to be prepared. We don't want to be, I mean, for me, I would think the liability is we know we could have done this and we chose not to do it, and then a student potentially, suffers injury or dies. To me, that's the liability. So California has a very good legal structure in terms of protections from liability around use of naloxone. Anyone can use naloxone. Anyone can distribute naloxone. It can be acquired for free through the State Department of Healthcare Services. You're protected from liability if you use naloxone on somebody else. So that's part of what I would say. But otherwise, I would say reach out to other folks who've been doing organizing on college campuses around the country and figure out what's worked for them. And also, I mean, the UC system is the UC system. I don't know what other UCs have done potentially about this. I don't know what Berkeley has done around this, for example, but there might be other UCs that have have policies that they were able to put in place. And so the Davis folks may be more responsive if you can show that, Santa Cruz has this or Berkeley has that sort of thing. I will say, as a UC Berkeley alum, it's a little wild to be back here in this building talking about these things. But.
This is Laura's jam, by the way. I don't need to add anything, but Zoe, right? I want to also echo and say thank you for organizing. And there's something you said at the beginning that I just wanted to come back to. Just to remind people that harm reduction and abstinence are not divorced. They're actually underneath the same umbrella. Sometimes people will say, I'm practicing harm reduction. And I think what they're saying is, I'm practicing moderation or safer use. But in harm reduction, there's also, abstinence is also on the continuum as well, too. I just always want to remind people of that, because it gets into this conversation about this versus that. And we've decided in the harm reduction community, we're not going to have that fight. People want to have that with us, cool. But I think it's all underneath the umbrella. AA, NA, 12 steps, I think it's all underneath the umbrella.
Yeah. I don't know much about policy or anything, but I'm also kind of the person who doesn't wait for a policy to be passed, because this is a life or death situation. So I would recommend reaching out to an organization that carries naloxone and having, maybe you can do your own trainings with students. I wouldn't wait. My organization didn't wait to start giving out naloxone and needles, and I encourage those to not wait either.
Hello. So I want to thank you guys for sharing today. It's super informative, and I really enjoyed it. And side note, before I ask my question, Ale, the TikTok program that you were talking about is harm reduction services in Sacramento. I also follow their TikTok. I think you guys should too. Great. But yeah, so I had a question regarding like the technology aspect of it. I've heard of harm reduction vending machines getting put out. And I had some questions about like how these vending machines are being like unmanned. There's no like liaison to answer questions, especially for people who like don't want them there. So how do you mitigate that misinformation when there's no one to provide accurate information at these like sites?
Yeah, there are a number of different programs just in California that are providing naloxone through vending machines. So one really fantastic program is in the LA County Jail, where they do trainings for folks while they are in the jail, and then as they are leaving, they have the opportunity to access naloxone from a vending machine there. Plumas County has also been doing a great vending machine project there. So, I mean, I think, the more we can give people access to stuff when they need it, the better. Like, there doesn't necessarily, naloxone, honestly, is incredibly easy to use. And there's, honestly, there's no reason that it is still technically a prescription-only substance, but that's a whole different conference. And so, I think vending machines have a lot of potential because somebody can go and access them potentially like in the middle of the night, or, a lot of our harm reduction programs, Punks with Lunch, Hyatt, San Francisco AIDS Foundation, we're only open for certain hours. Like sometimes we're like, we're open for 2 hours on a Tuesday evening behind the Safeway, things like that. And so you want to have more access, and that's what the sort of opportunity of vending machines are. And I think you have those conversations with the neighbors before it gets put in. You have those conversations about what it does and what it doesn't do and who's likely to be accessing it. You make sure that the neighbors are hearing from the people who would be using it about what value it would hold for them. you know, and make it clear that it's adding value to the neighborhood or to the community and not creating a harm or a danger. I think you just have to have all those conversations probably over and over again in order to, you know, to get those sorts of things up and running.
Yeah, I wanted to uplift a story. There's about 5 years ago, an encampment we worked at, somebody had an oh shit kit, which was essentially a place for naloxone and syringes, and we would put flyers in. We post flyers around it. We would help them keep it stocked, but it was, you know, ended up getting torn down. But it was in terms of having communication with people, not being right there, having flyers and talking with the surrounding neighbors. But I thought it was a cool story to bring up.
I mean, and I don't need to add much. What I'll just add is that it's in harm reduction, it's super important that things are accessible, like you were saying, and low threshold, that are easy to get at.
Thank you so much for your time here and the perspectives that you're sharing, and really pointing out the importance of harm reduction as a response to our harm in this in this complicated puzzle. I'm hoping to understand a little bit more if you could share in the context of cases, you know, where like Purdue family, or Purdue Pharma and the Sackler family knew the risk and the risk that opioids like oxytocin posed. So how, rather than sort of thinking about this through the context of harm reduction, how can we transform this more to like restorative justice or a mechanism of accountability for people who've instilled this type of harm?
Yeah, that's an extremely good question, and thank you for framing it in the context of restorative justice. You know, the Sacklers and Purdue Pharma, again, some of it goes back to capitalism, right? Like, they clearly were doing a lot of very intentionally misleading marketing in order to reap substantial profits, corporate and personal profits. And from that perspective, I'm happy to see these sort of lawsuits that have gone after their profits particularly. However, it has also, I think, led to this idea that everything that's happening in terms of overdoses are because of overprescribing and because of the Sacklers and Purdue. And the reality is, as we've talked about here, what makes people vulnerable to an overdose is often their economic and social conditions. And the reality is that very, very few people develop problematic substance use because they were prescribed opioids for pain. That is a narrative that you hear a lot, that, you know, the Sacklers are responsible for this overdose crisis that we're in. And while there were certainly, you know, doctors overprescribing and the Sacklers trying to make money off of this, that ultimately is not what has led us to be in the situation that we're in now. And going after them as if that's going to solve it, trying to crack down on doctors who are overprescribing, has just left chronic pain patients without pain management, right? It has directly led to increasing people's suffering, and the sort of anti-opioid pendulum in the medical world has swung so far, right, that now pharmacies don't want to even stock buprenorphine, Suboxone, which is the treatment for opioid use disorder. Doctors don't want to prescribe opioids even to people, chronic pain patients who've been safe and stable and functional on opioids for decades. And so it has, even though it is trying to come at this with a restorative justice approach of we're going to take back this money and redistribute it, often that money ends up getting redistributed to, you know, to police or to, you know, faith-based abstinence-only programs that are creating more harm than good, or to something completely unrelated to opioids. So it's worth keeping a very close eye on that, and also pushing back on these narratives. Like, Hulu had this, dope sick TV show that was just full of very, let's just say, unevidence-based assertions about stuff. And so, any drug in and of itself is never the problem, whether it's crack or meth or, OxyContin. The drug in and of itself is not the problem. It's the context in which it gets used, and the context in which some people are more vulnerable to developing problematic substance use. Some people are more likely to be criminalized for it. Some people have less of a personal safety net, so one small problem results in a whole, spiraling set of things. But so, yeah, that was not really answering your question so much as pushing back on some of the narratives, but thank you for asking that, and I do think there are really opportunities to think about this from a restorative justice perspective of what does that mean when you try to take money back that capitalism has extracted from individuals and communities and use it to repair the harm, and what are good ways to do that and what are bad ways to do that.
One statement is that capitalism does not have a process for restorative justice for rich people, period.
I think that's a great note to end on. Thank you again. This was a really, really awesome conversation. That is all. After this, we're going to be going to workshops. Thanks.
Thank you.